Hello, everyone. A very warm welcome to this webinar. The title of the webinar is the Novel Diagnostic Tools for Optic Neuropathies and Glaucoma. My name is Leopold Schmetterer. I'm the Scientific Director of the Singapore Eye Research Institute, and I also hold professorships in Vienna and in Paris. So when we talk about diagnosis of glaucoma, we have a couple of diagnostic tools available. And these diagnostic tools should ideally have high sensitivity and specificity. If possible, there should be an objective reading to minimize user dependence. It should allow to obtain information that is unavailable via any other available instrument. It can hopefully be applied to many diseases, not to glaucoma only. It should have a short measurement time, should be easy to operate, and of course it should have high reproducibility. But even if a diagnostic tool fulfills all these requirements, it is not the diagnosis itself. It's just a support system, a tool, and usually the diagnosis in itself, it is still a clinical judgment. Now, let me start with a polling question. What do you primarily use as diagnostic support tool in glaucoma? Is this standard automated perimetry? Is this fundus photography? Is this optical coherence tomography? Or is this something else? You can vote now. We have approximately 30 seconds for you to vote, and then we will show the result. So please vote now. And once we have the results, it will be shown. Yeah, so you can see that the majority of people here use optical coherence tomography. This is a little bit more than 50%. Approximately 1/3 use standard automated perimetry, 10% fundus photography, and 5% other. Okay, thank you very much. So generally, we can distinguish between techniques that quantify the functional damage of glaucoma and those techniques that quantify the structural damage of glaucoma. And I do already come to the second polling question. Do you think that structural assessment of glaucoma is superior to functional assessment in early stage disease, in late stage disease, in all glaucoma stages, or functional assessment is always superior to structural? This is the results, yes, and I agree with approximately 50% of the audience that particularly in early stage disease, the structural assessment may be superior to functional assessment. And I think we will go through this and discuss this question throughout the course of this seminar. So, of course, the standard technology for assessing functional damage in glaucoma is standard automated perimetry, and I'm sure you are very familiar with this technique. There is a couple of different instruments available. I think the most widely used nowadays is the Humphrey system, and you can see here the different ways of how the results are displayed in this grayscale or also with numbers. And usually the systems also have an automated way of looking into progression. So this is a typical progression analysis where you can look into either the GPI or the mean deviation. And you can see here the system usually also provides you with a likelihood of progression. This is a very clear case where you see progression over time, also with relatively little variability, so that you can be quite sure that this patient is progressing. Now, one of the big problems is how many actual visual field tests do you need in order to be able to detect progression? And this is from a classical paper of Balchahan, which is now more than 15 years ago. And you see this depends on the standard deviation in a subject. And if you, for instance, want to detect 1 times the standard deviation in a subject as a significant progression, you can see here that you need approximately 7 to 8 visual fields. And this is a lot because 7 to 8 visual fields is time consuming, it can be costly, and it depends on your setting how often you see a patient. So the variability of visual field testing can be quite severe. Another problem with visual field testing, and this has been shown, for instance, in this paper from Portland, is that when certain locations have sensitivity below something like 15 to minus decibel, the visual field testing is not reliable anymore because there is no linear association between the sensitivity and the stimulus intensity anymore. So what is the state of art for detecting visual field defects? Summarizing, it is definitely the standardized automated perimetry. There is a problem, and this comes from a very recent study, that you have quite a bit of variability, and you see here generally the more advanced the visual field defect, the higher is the variability. So at minus 10 dB, the mean variability is already in the order of 4 decibels. And as such, we have a number of limitations with standardized automated perimetry. This is particularly the high variability, the subjective testing, the relatively long procedure, although the newer developments go into faster procedures like as the SITA fast. You have a learning effect that often mimics an improvement in the visual field. You usually have undersampling because you do not detect so many patients, and this is particularly critical if you have a very central visual field defect and you have nonlinearity in severe visual field defects. Please also note that in some subjects the variability is very low, and then you can very nicely detect progression. But in other subjects, you can see here the variability can be as high as 10 decibel in this subject, and then you almost have no ability to detect any change over time. There have been attempts for automated visual field testing, but the problem is that none is really used in clinical practice. Here I show you 3 of the key techniques. This is multifocal electroretinography, multifocal visually evoked potentials, and multifocal pupillographic objective perimetry. And the reason why these techniques have never made it into clinics is because they are too complicated and too time consuming. Actually, we would like to have techniques that give a very, very fast assessment of the visual field. And these automated techniques do not really fulfill these requirements. So they are used in research settings, but not so much in clinics. Now let's move from functional to structural images. And here we have basically 2 techniques that are state of the art. This is fundus photography and optical coherence tomography. Nowadays, both of these techniques are very mature. You know that fundus photography has moved towards wide field in the recent years, and optical coherence tomography saw a lot of improvements, particularly with the introduction of spectral domain techniques. When we look into the images, we can either extract semantic features defined by human experts or agonistic features defined by equations. What are semantic features? This would typically be fiber bundle defects as seen on fundus photography, optic disc hemorrhages, or CD ratio from fundus photographs. Agonistic features are, for instance, ganglion cell complex, nerve fiber layer thickness, or a quantitative measure of optic nerve head cupping. Now here you see fundus photographs, different types of glaucoma. All these patients here do have glaucoma here, and usually when you use fundus photographs, what you do is that you, as according to this definition, that you use semantic features to assess whether this fundus is glaucomatous or not. This can be complicated in some cases, particularly if the optic disc is very small or it is very large, but also, for instance, if the fundus is highly myopic. A very characteristic feature and a sign of progression is also disc hemorrhages. Here you can see different types of disc hemorrhages, and these disc hemorrhages are always a sign of future progression. Usually in this area where the disc hemorrhage occurs, there will be a further progression of the nerve fiber bundle defect, and it is an interesting feature that can only be seen on the fundus photograph. It is usually not seen on OCT images. Now, for OCT in glaucoma, we basically have two types of scans. These are optic nerve head scans for measurements of retinal nerve fiber layer thickness. So you have the circumpapillary scan that you see over here, and then you get this type of like in B, this type of nerve fiber layer appearance, and then you simply have this as green, yellow, or red. Just to remind you what this means, the green is within normal limits. That means that it's within 95% of the normative database. The yellow is borderline. This is between 95 and 99% of healthy subjects. And red is outside normal limits, and this means that you are outside 99% of subjects. We can also use macular scans for measurement of ganglion cell interplexiform layer ganglion cell complex, and this you can see here. This is the GCIPL, so the ganglion cell plus the inner plexiform layers. Some systems also assess the ganglion cell complex in itself, or the ganglion cell layer. This is a little bit different between instruments from different manufacturers, and this is usually also something that can be used to assess the integrity of the ganglion cells and of the retinal nerve fiber layers. This is usually done from volumetric scans of the macula. So, as I said, there is a comparison with an established normative database. It is a problem that the databases of the different manufacturers is maybe not as large as we would like them to be. Usually, they contain only several hundreds of healthy subjects, and this needs to be taken into account. But what you see is, you can see here whether this is green, yellow, or red, and you can see here that in this case, here you have one yellow segment, and here you have two red segments, one superior and one inferior. Now, there is a couple of confounding factors. The first confounding factor is the age. Generally, we lose retinal nerve fibers also in healthy aging, and this is particularly true when we are relatively young. You can see here the curve is very steep until the age, let's say, of 50, and then slows down when you move towards your 80s or 90s. And this is something that needs to be considered, not every decline that you see in the retinal nerve fiber layer is due to glaucomatous damage, but it can also be a sign of aging. And you have to very carefully look whether a decrease that you see over time is age-related or a sign of glaucomatous damage. A second thing that you need to take into consideration is that there is a difference between males and females, with males having slightly thicker retinal nerve fiber layers. You can see that the effect is not very pronounced. It is only 1 micrometer, but it is still something that you may want to consider. Another problem, and this is a much bigger problem, is that there is a lot of differences between different ethnicities. And you can see here, this is from work that we have done in Singapore. This is from an epidemiological study, including Chinese, Malay, and Indians. And you can see here that, interestingly, Indians have much, much thinner retinal nerve fiber layers than Chinese or Malay. We do not know the reason for this, but it is a matter of fact. And this is very critical because if you use, let's say, a database, a normative database that consists of Chinese, and you apply them into Indians, you would have a lot of red segments erroneously, and this will maybe result in overdiagnosis of glaucoma. What is also important is that there is an effect of axial length. The retinal nerve fiber layer thickness is the thinner, the longer the eye length. This needs to be considered in myopic and highly myopic eyes. And there is also and this is definitely something that needs to be considered. You can correct for this potentially with magnification, but this is something that needs to be considered. Now let's talk about how good these systems are. So how sure can we be if, let's say, there is a red segment that this is glaucoma? And actually, the area under the curve is not bad. If you look here, that you have overall pretty good diagnostic performance, but it is very much dependent on the stage of the disease. And you can see here that there is an almost linear correlation between the area under the curve RC value and the visual field mean deviation. So the worse the glaucoma, the better is the area under the curve. Well, this is also no wonder, because the more pronounced the visual field defect, the higher, of course, also the structural changes. And as such, it can be understood that at very late stage glaucomas, the diagnostic performance is good. But please also take into consideration that in early stage disease, the AOC is not so good. So what does this mean in practice? It particularly means that not everyone who has a red segment or a yellow segment has glaucoma. It can also be due to physiological variants that causes this thinning. I'm often asked the question, what is better, the optic nerve or the macular scans in detecting glaucoma? And there is no simple answer to this. Overall, in the majority of studies, the AOC is comparable. So it does not make a lot of difference if you use the optic nerve or the macular scans. It is, however, true that in patients that have very central scotomas, and those patients that are highly myopic, the macular scans may be preferable, whereas in those that have very peripheral visual field defects, the optic nerve head scans may be preferable. Also here we have to look that the average nerve fiber layer thickness, and I've said this already, has a age dependence, and you have to be very careful to look whether really this is progression or an age-related decline that you see over time. And as you can see here, this also depends on the age. Please consider that particularly in young subjects, there is a very strong decrease in retinal nerve fiber layer thickness over time, also with healthy aging. When we look into progression, there is two ways to do this. This can either be trend or event-based analysis. What is the difference? Event-based analysis identifies progression when a measurement exceeds an established threshold for change from baseline, and trend-based analysis assesses progression by evaluating the change of a parameter over time. So event-based analysis is always dependent basically on one single exam that exceeds a certain threshold. Trend-based takes into account all the measurements that are available. The advantage of trend-based analysis is that it is less susceptible to outliers than event-based analysis, but generally you require multiple tests to be reliable. And I have shown you already before for the visual field defects, if the variability is high, you may need very many investigations, very many measurements over time to be able to detect progression. So here we can see that the difference, here you see a trend-based analysis where you see basically the regression line over time. And here you see an event-based analysis where you can see that here there is a significant difference from one measurement to the other, and this is very significant that here there is a loss of retinal nerve fiber, and you consider this as significant. What is better, optic nerve versus macular scans for progression analysis? Again, we do not know. This is not simple to answer, but what is true, and this is quite interesting, there is not such a good agreement between them. So whatever you take, you can detect progression, but consider here that the overlap between optic nerve and macular scans for progression analysis is not so good. Another thing, and this comes back to the question whether you should use structural measurements in early or late stage disease, is the so-called floor effect. And you can see here, this is structure function assessment. So on the x-axis, you have the global visual field sensitivity in decibel, and on the y-axis, you have the retinal nerve fiber layer thickness. And you can see here in early stage disease, when there is not yet any visual field defects, you do already potentially see changes in the OCT. And this is because we have a certain reserve of ganglion cells. So a healthy subject can lose approximately 30% of ganglion cells without having any visual field defects. And this is the reason why OCT can often be more reliable than visual fields in detecting early damage. But when we go here to late stage, you see here from -10, -15 to -30, -35 dB, there is a so-called floor effect. So when the visual field is still declining, you do not really see a change in the thickness of the nerve fiber layers. Why is this the case? This is the case because you have a residual thickness when you measure the retinal nerve fiber layer. And even if all retinal nerve fiber layers are gone, there is still a layer because there are glial cells and blood vessels in this layer. And this means that there is always a thickness that you measure, even if it does not consist of nerve fibers anymore. And you also have to be aware, and this is shown here on the right, that this very much depends on the instrument that you use. There is different thresholds for this floor effect with Cirrus spectralis and RT-view for the instance. Now, one very important question in glaucoma diagnosis is always the structure-function relation. And I've asked you before, what do you actually use? Do you use visual fields? Do you use OCT? Or do you use fundus photography? And what is important to assess when you have all these three techniques or other techniques in addition that you use, is there a quite reasonable structure-function relationship? And this can be easily assessed here, for instance, with this Garway-Heath map. That is a map that it was introduced by Ted Garway-Heath some 20 years ago. And you can see here, if you have here in this yellow part a defect of the retinal nerve fiber layers, you would expect that the visual field is affected in these yellow areas. And you can see here whether this is associated or not. As you can see here, you can see in glaucoma subjects how well this is fulfilled. Now you can also do this with the macular OCT data versus the visual field, both for the GCL and the IPL, and you see that there is also a pretty reasonable structure function assessment. And generally, when you look into the diagnosis of glaucoma, but also when you look into glaucoma progression, it is always very important to understand, is the structural damage consistent with the functional damage? Now, let's go a little bit to the future, and this is my polling question number 3. Would you be willing to use artificial intelligence in the future? And we have again 4 opportunities: for diagnosis, for screening, for progression prediction, or for all of the above. Or, we have 5 potential answers. Or you would not at all be willing to consider artificial intelligence in your clinical care. So I would now ask you now to again vote what is the right answer for you personally. And again, we have approximately 30 seconds. And once this is up, we will show the results. And it's interesting, the majority of you is very, very open to use this. This is approximately 75%, so a very high proportion would be willing to use AI. And interestingly, and this I find very interesting, it is the least for diagnosis. More for screening, progression prediction, and only a small minority, 8 of 207, is not willing to consider this. Now let's look a little bit into the science of this and where we stand with all this. So what is the concept of machine learning approaches? I have shown you before that there are semantic and agonistic features, and generally machine learning uses agonistic features but does not use mathematical description or modeling, but uses a black box approach. So classical machine learning approaches are 2-step approaches. We train a convolutional neural network in a training data set where the clinical diagnosis is the gold standard. So basically, we have a data set where we know clinically this person has glaucoma, this person has no glaucoma, and then we have images and train based on the images to do a better estimation whether this is glaucoma or not. And once we have done this, we validate the convolutional neural network in an independent validation data set. And in this independent validation data set, the clinical diagnosis is also known. So there is a lot of critical step in machine learning approaches. The first is whether the sample size in the training data set is sufficient. You all know that usually very high number of data is required to make this network work. Is the performance in the validation data set as good as in the training data set? This is another critical thing that is also related to usually to the number of data, because you can have overfitting of data where the CNN performs well in the validation, but not in the training data sets. Then are the right features selected to correctly model the selected problem? And do we really achieve gain in the survival? So this gives you an idea how such a convolutional network works. You have here an image and you extract features via convolutional and max pooling layers. And then finally you have a softmax layer. And in this softmax layer, the easiest form is glaucoma yes here and glaucoma no here. And this is how such CNN works and why it is called convolutional neural networks, because this is similar to how our brain would assess such an image to extract features from an image. Now, I'm not going into all the details of glaucoma detection. I'm sure you have heard about this, and there is multiple excellent review articles, and you will see that there are now hundreds of different CNNs how you can detect glaucoma based on fundus photography, OCT, visual fields, clinical data, or a combination of those. And this actually outperforms all other techniques. But the real question, and that's the reason why I started with this polling question, what should we use AI for in glaucoma? There is three ways you can use for diagnosis, you can use for screening, or you can use for follow-up and progression analysis. So it is very important to understand that the application in screening and diagnosis is something completely different. In diagnosis, it is mainly AI can be seen as an improved diagnostic tool. So basically, you again do imaging or visual fields, and it is simply an improved version of the diagnostic tool in itself. This is totally different in screening. And there are major differences between screening and diagnosis. Screening is done on an apparently healthy population. Diagnosis is done in sick individuals. Screening is applied to groups. Diagnosis is applied on single patients. In screening, the results are arbitrary and final, so a screening result can only be 1 or 0, whereas diagnosis is not necessarily final, and you know that in clinics there is often a diagnosis of glaucoma suspect where only in the follow-up it will become clear whether the patient does have glaucoma or not. So the screening is based on one criterion and the cutoff. And this is the diagnosis is, however, based on several findings and clinical experience, and only this clinical experience can help you with the final diagnosis. Screening must be less expensive, diagnosis can be more expensive. As such, screening will be less accurate, diagnosis will be more accurate. Screening can never be a basis for treatment, but a positive screened patient needs to go into diagnosis, and this can be the basis for treatment. And for screening, the initiatives come from the investigator, for instance, from the insurance company or also the government, whereas the initiative for diagnosis usually comes from the patient seeing an ophthalmologist. Now, one very important thing, and one thing that is very critical, is whether we can detect progression. And this is the final part of my talk, and I would like to introduce to you a concept of G-risk that we have developed, that this is a new idea. As I have told you before, usually you use fundus images and you look into semantic features. So visual nerve fiber fundal defects or cup to disc ratio, or potentially also hemorrhages. Now, what we have looked is whether we can quantify the degree of damage with an automated assessment, deep learning-based assessment of the cup to disc ratio. And this has the advantage that you basically don't, as in normal in deep learning, have healthy and diseased, which does not really fit the situation we have in a population, but we have non-glaucomas, we have glaucoma suspects, and then different degrees of glaucomatous damage. And this has been validated in a very large number of different data sets as requested. And then later, and this comes to progression analysis, we asked ourselves a simple question. Can we take one single fundus photograph and determine the risk of these patients for future progression? So only do one fundus photograph and then see, can we predict how high is the risk of progression? And this is G-risk slope progression. And as you see, we had a lot of data, approximately 150,000 photos from Belgium, Finland, and China. And this is the overall progression here in terms of mean deviation and in terms of RNFL. And you can see that this is pretty messy because you have some that even get better over time. This can be learning effects also, but there is some patients that have a very, very dramatic decrease in the visual field over time. These are the red ones. And the question is, can we identify those red ones? Now, we started with several auxiliary models. In these fundus images, we automatically detected the disc location. We automatically estimated the image quality and the eye laterality. And then we only included patients that had at least 5 good images in a row in a certain interval, and these were included. And then we defined this G risk as slope as a novel biomarker for structural glaucoma progression. So this is the G risk, and if here the slope was significant, we called this a progressor. And then the question is, can we predict this from the baseline fundus image only to detect those that are very fast progressors? And you can see here, amazingly, this functions pretty well in the validation and test data sets. You get AOCs in the order of 0.8 to 0.9 when you have 6 visits, and it even works pretty well in early and late stage glaucoma. Generally, it works better in early stage glaucoma. You can see here that it works almost equally well in the different data sets, except for the Finland data set, but the Finland data sets are also macular-centered images, so generally it works better in optic nerve-centered images, and this shows you again the overall performance reaching almost up to 0.9 in predicting progression. And let me show you one case, and this is an interesting case that stems from China. This is a 40-year female. You see here the fundus photograph, and it is glaucomatous without any doubt, but it is not very severe. It is maybe a mild to moderate glaucoma with an MD of -5 decibel. The patient, this is the first visit, had an IOP of 25 millimeters of mercury. And the question is, of course, what should be the treatment and what should be the follow-up interval? Now, the patient was put on latanoprost, but what happened after 2.8 years is that the mean deviation was -23 decibel. And you can see here, this is the progression over time, a very dramatic progression. You can see here that the patient after 3.5 years was almost blind with very, very severe structural and functional progression. So -6 dB a year, so a catastrophic progressor. And this was actually identified by our algorithm. So the question is, of course, if you would have known this prediction, would you maybe have treated much more aggressively and reduce the follow-up to these patients in order to prevent this dramatic loss. And with this, I would like to thank you for your attention. Here are pictures of Vienna, Singapore, and Paris, and this is the cities where I currently work. And I'm very happy now to discuss with you and answer your questions. Thank you very much. What AI tools are you currently using in your daily practice things? Yeah, this is a very important question, and the answer is that we are at the stage trying to implement this in the clinical workflow in the clinics. We would like, so we have three programs. The first is a screening program. And for the screening program, we currently use this as part of the diabetic retinopathy screening program. So in Singapore, we have a diabetic retinopathy screening program. And what we are doing is we are now starting also to look into glaucoma in this diabetics as a test phase. The second thing is we use AI tools supportive for diagnosis. And when the people do OCT, we give them in addition a percentage likelihood that the AI would consider that this is glaucoma. And the third thing, I've shown you the glaucoma progression analysis tool. We also have one for visual fields. And this is currently at the stage where we try to implement this. I must also say one of the problems in implementing AI is you first need to have all the IT solutions available. And this may sound very simple, but in reality, it is difficult to implement this and of course to have this. Yeah, in your last case, should we think about non-glaucomatous optic neuropathy as differential diagnosis? This is not our patient, so this is a patient from China. I actually don't know. This is something that definitely needs to be considered. But on the other hand, the AI also thinks that this is glaucoma. So I do not have all the I do not have the electronic medical record for this patient. I only have the data that I have shown to you. But it is something that needs to be considered, but it is not the only patient that has this dramatic, very dramatic decline in visual fields, and it is rare to have -6 dB per year, but it happens, and it even happens sometimes under treatment. So if a patient is glaucoma suspect, you cannot start therapy unless you diagnose them as mild glaucoma. No, not necessarily. I mean, this depends on a lot of things. This also depends on the level of intraocular pressure. This may depend on other risk factors as well, for instance, family history of glaucoma. So I would not necessarily say this, and you can definitely have a good diagnosis of pre-perimetric glaucoma if you have a very clear fiber bundle defect, for instance, that you see both on the OCT and on the fundus photography, and it is not yet seen on the visual field. I think this you can start treating these patients, but it depends, of course, also on the level of intraocular pressure. What would be your target? What is the future of visual field analysis? Well, I would say there is three ways of moving forward. The first way of moving forward is to have better tools to analyze visual field data. So the better tools include statistical methods that, for instance, also are the basis for CETA and CETA fast, so that you can have faster assessment. The second thing is you can look into AI techniques, and I haven't shown this today to you because of time constraints, but generally AI can help you in identifying visual field defects that are due to fluctuation and those that are real. And the third is on a little bit of longer perspective. There is a technique called optoretinography, and this is based on OCT and flash stimulation, a technique to assess the function of neurons. This can be done both in the outer retina with photoreceptors, but also in the inner retina. I think there is a lot of hope associated with this, and there is very intense research. I'm also doing a lot of research in this field with my team, but it definitely will take some time until this is taken up clinically. Although the vendors, they have an interest in this technology, and I hope that in the future this will be an objective technique to assess visual function. What is the future of screening in glaucoma? Will more people require a routine glaucoma check? Yeah, this is a very important question. So let me summarize shortly. Basically, when you screen for glaucoma, you always have to look into the sensitivity and specificity of the test that you are using. Now, the problem is it depends on the prevalence of the disease, how many false positive and false negatives you will get. And if glaucoma is not extremely rare, but it is also not extremely prevalent. So it maybe has a prevalence between 2 and 4%, depending on the population. So you have to be very careful that in your screening, you do not mainly get false positives. And this is very, very risky, because otherwise you will have much more people require a routine glaucoma check that do not have glaucoma. On the other hand, you also don't want to have too many false negatives, because then you say to people you don't have the disease and they actually have the disease. So this is a very critical balance. I think what is the solution to this, and this has not yet been defined in very much details, what is a good threshold for glaucoma screening? My personal view is that we do not need to screen for early glaucomas. And the reason is the following, that patients who have very early glaucoma, particularly pre-perimetric glaucoma, they have very, very low risk to get blind, let's say in the last 5 years. It is in the next 5 years, sorry. It is particularly those that have already advanced glaucoma when they are diagnosed that have a high risk of getting blind. And this, I think, is really the goal, that we would like to identify them at a stage where the progression is already relevant. But I can't tell you at the moment what is actually a good threshold for this screening. I think at the moment, as it stands, we have several programs, including the one in Singapore, where we try to start to screen for glaucoma and see how this actually works. But there is not yet a single country or a single insurance that really does mass screening. But I think it is important to have this in the future. It is important to identify those glaucoma patients who are at high risk of getting blind. In the last case, how can you see that the progression can be that dramatic? If there is a way to know? Yeah, I mean, definitely what we know, and what is definitely the case, is so we know two things. On the one hand, we know that lowering intraocular pressure decreases the risk of progression, but we also know that even after lowering intraocular pressure, there is a very wide variability. There is many patients who are actually stable over time and do not progress or show only minimal progression, which is very unlikely to affect their vision significantly during their their life expectation. And then there are other patients that have a very, very high risk of getting blind, and you can lower the intraocular pressure a lot, and still these patients progress. Obviously, with AI, you at least have a tool to identify those who are at very high risk of progression. And I think this is something that in the future will help to reduce the incidence of blindness. Je peux savoir la manière pour faire yeah, maybe this goes back to the question of OCT and the how OCT will perform in the in the case also of early and advanced studies. Now, as I said, in the late stage, OCT performs pretty well, even though there is a floor effect, because the damage is very severe. But honestly, also in the late stage, usually you don't need OCT anymore to diagnose glaucoma, but you'll simply look through the slit lamp, but it's anyway obvious. In the early stages, and this is something that is very, very important, only because a patient has a yellow or red segments, that does not mean it is glaucoma. Many, many healthy subjects also have red segments. For instance, in highly myopic eyes, or also often in eyes where the vessels have an abnormal angioarchitecture and they enter the optic nerve head at positions that are anatomically not very frequent. And then you can often have red segments, but this does not necessarily mean glaucoma. That's the reason why it is also very important, if you have a red segment or a yellow segment, also look into the visual field and the fundus photography and see whether such signs of glaucomatous damage are also on the in the other techniques, whether you can see them in the other techniques. Is there a possibility to access a resource where to refer suspect images for prognostic evolution? I'm not aware of this. Maybe there is some, I would expect that maybe in some countries there is local services available, but I'm not aware of a resource where you can simply upload the data and you get the feedback back. I think this has two reasons. So the one thing that makes it difficult is the patient privacy, that you are not allowed to upload data somewhere without having the consent of the patients to do so. And the other question, if you do this centralized, and let's say an experienced glaucomatologist is sitting somewhere and looks into the images, who should pay for this? And I think that's, I'm not aware of this, but maybe it exists and I simply don't know. Is AI-assisted glaucoma progression analysis as reliable in pediatric glaucoma as in adult glaucoma? The answer is definitely no. And the reason why this is not the case is because we don't simply have enough data. I told you, if you want to have an AI solution, you need a lot of data. You have seen that for our AI solution, we currently have 150,000 images available. And the problem is, of course, in rare disease such as pediatric glaucoma, you will never get this number of images to be able to do this. There is now modern ways of where we try to enhance data sets, let's say, with fake data, like either with GAN technology or with diffusion AI models, but this is pretty far from clinical applications. But I think this is a very important question, and it highlights the problems of using AI in rare diseases. This is not only true for pediatric glaucoma, but this is also true for other rare diseases or the optic nerve head, or generally for all hereditary macular disease. Can AI differentiate between glaucoma and glaucoma suspects or other optic neuropathies? Again, a very important question, and again, a question that is not easy to answer because glaucoma is simply much more prevalent as other optic neuropathies. And to have an AI system that differentiates between glaucoma and optic neuropathies, you would need a very high number of defined diagnoses of optic neuropathies. There are people, including our group, working on this, but this is still at an early stage. Glaucoma suspects, yeah, this is interesting, but for glaucoma suspects to do this, you need a long follow-up to actually see at the end of the day whether this is glaucoma, yes or no. Because if you don't have the ground truth at the end of the day, you also cannot train the AI system. So definitely, I would say that a very important question, and we would like to do this, we would like to have this, but this is very, very complicated to collect data to be able to do this. If a patient has intraocular pressure within normal limits, but there are red color changes on the OCT, what do we do next? I think this is also a clinically very important question. It depends, of course, on the other techniques. It depends on the visual field. It depends on the fundus photography. It depends on the age. It depends on the family history. But generally, definitely, if there is nothing else than a red segment, the patient needs to be followed, let's say maybe every 6 to 12 months. But there is no need to initiate treatment. And we have often talked about undertreatment in glaucoma, but I'm very convinced that there is also overtreatment in glaucoma. Some patients are treated for glaucoma that actually do not have the disease, and it is always very important to indicate this. If, however, there is a red color change on the OCT, and you, for instance, see on the fundus photo a corresponding nerve fiber layer defect or a corresponding hemorrhage, yeah, then it's different. Then if you have two diagnostic tools that point towards the disease, then there is definitely a much better rationale to initiate treatment. What are the challenges in AI implementation when many ordinary clinicians may not be well versed in AI methods? Again, a very, very good question. My view is the following. It depends very much on the setting of your healthcare system. So in Singapore, for instance, the government is supporting such initiatives, and they would like to have standardized tools available to all ophthalmologists within the country. Now, in other countries, this is not the case. And as such, I cannot give you an answer immediately what is the best way to do. What I definitely think, and this is complicated, in a clinic, you need people who know how to implement this. And this is not trivial. This is the one thing is to have an AI that works in principle, and the second is to involve it into your clinical workflow. And this is very different from, let's say, a private clinical practice to a hospital. My hope is, and this is also where the field is moving, that the vendors will start to make AI solutions available on their systems. And I see that with the big vendors like Topcon or Heidelberg also Zeiss and Nidec, this is happening already. Do you think pachymetry is useful in glaucoma? Yeah, of course, pachymetry is useful in glaucoma because it depends on the level between the real intraocular pressure and the measured intraocular pressure, as you know, is dependent on the thickness of the cornea. But first thing is usually you only have to do it once because the choroidal thickness will not change over time, and you need to take this into consideration with when you look into your IOP readings. You can use pachymetry in addition, but it is just an adjunct tool to correct for intraocular pressure. It is particularly important in those patients that have undergone LASIK therapy, where definitely the IOP values will be incorrect when measured with applanation tonometry. Next question. I missed the first 10 minutes of the presentation and might have missed what you said about electrophysiology. Yeah, and ERG. I think the problem is these techniques take too long. I mean, I have done electrophysiology myself, but not for clinical, but for research and also VEP. And it is simply a lengthy procedure. It takes a long time until you get a reliable result. And this is not what you want to have in clinics. This is what I said in the very beginning. You want to have a system that is fast and easy and can be operated by a technician. This is also because of cost effectiveness. What you definitely don't want to have is you spend 15-20 minutes with the patients in order to get a reliable multifocal ERG or VEP. This is not doable in every patient in a busy clinics as you all have. And as such, I feel that these are all research tools. They are interesting, but none of these techniques has yet made it into the clinics. How many times and at what intervals do you repeat a visual field to validate the presence of a visual field defect and or progression of a defect? Well, optimally, you would usually do 3 visual fields at baseline after diagnosis within a relatively short period of time. The problem is, of course, this depends very much on your reimbursement system because many insurance systems do not pay for this. And the question is, of course, it depends. The patient can, of course, pay privately for it, but the problem is that it is not really easy with having one baseline, particularly also with the learning effect, to see whether there is progression or not. A big problem. You can only try to convince the insurance company to pay for more visual fields at baseline. What are the use of OCT angiography, virtual reality, perimetry, swap, and FFDT in the screening of diagnosis for glaucoma and neuropathy? Well, OCT angiography, I feel that this is an interesting tool, but it is still a research tool. It is not yet at the stage that we can really use this clinically. This is, by the way, in opposite to retinal disease, where definitely OCT angiography has its value. In glaucoma, it has not really been shown, and one of the reasons also because the OCT angiography is affected by a lot of diseases other than glaucoma. Just think about all the results that have looked into OCT angiography in systemic hypertension, where you see changes, in diabetes, where you, of course, see changes, but also in Alzheimer's, Parkinson, or multiple sclerosis. With the other perimetry tests, I'm a little bit skeptical, honestly. I do not at the moment see that this is really something that is gonna going to replace standard automated perimetry. As I said, I have the biggest hope related to optoretinography. The other things may be interesting, but I don't see exactly how this can be implemented in screening. I think one thing is very important. We would like to have, let's say, OCTs and visual field machines that are very cheap. And when I'm talking about very cheap, I mean like a device to measure blood pressure with oscillometry. Let's say something like automated oscillometry that you use and that costs $20. This would be great, but these techniques are not yet out there. If we would really have home monitoring, this would be a game changer. But home monitoring cannot cost 5,000 bucks. It can maybe cost $50, but not more. With all this said, you only did an analysis of those who had a very fast progression in their glaucoma. From your chats, there were those that had a positive result as though they were recovering. What could attribute to this improvement? Oh, this is a complicated question, and this is a question that is also scientifically not so clear. Why do certain patients improve in glaucoma? I think the biggest improvement you usually see is because of the learning effect, because when the patients first do their visual fields, they do not know how to do it properly, and they learn it over time like in a computer game. There is, however, also other reasons, and we know now very clearly that if you have a patient that has high intraocular pressure and you lower the intraocular pressure, you can sometimes improve the visual fields. And the reason is because ganglion cells at very high intraocular pressure can be dysfunctional. This is most likely related to mitochondrial dysfunction of these ganglion cells, and they can become functional again when you lower intraocular pressure. So particularly after glaucoma surgery, there is a significant subgroup of patients where the visual field increases because of this phenomenon. Do you think that these AI tools will work similarly in an African population, considering that most of the data were not collected in Africa? Yeah, this is a very, very important question, and unfortunately, a question that we cannot answer sufficiently because we all have problems to get data from Africa. And if you do have data from Africa and you are interested and willing to collaborate, just drop me an email. You anyway find me on the internet very easily. A very important thing, generalizability. And I have shown you that what is developed in Chinese does not work in Indian. And I'm pretty sure that solutions that were developed, let's say in Singapore, in US, or in Europe, would not necessarily work in an African population. The only way out of this is international collaboration. And the international collaboration, and this is very important, should not be there to foster careers, but is necessary for improved healthcare. It would, once you feed in local data, we have developed one to diagnose, classify, and detect progression in glaucoma. Is it being refined and would be available in the public space soon? Yeah, we are working on this, and this comes back to the question. As you've seen, we have 150,000 images so far. And what I did now is we have now access to 3 additional data sets. This is a total of 5 million fundus photographs. Just that you can imagine that analyzing 5 million fundus photographs with AI is a lot of work. And as such, we are still working on this. And definitely, we would like to make it publicly available. This is definitely a goal that it is also available for free. How would you assess the progression of glaucoma in high myopic patients? Will you take into consideration their RNFL as well? Yeah, I expected this question. I didn't talk about high myopia because this is such a complex problem that it would need another talk to look into this. And maybe Cyberside can at some point uh, invite somebody to talk about glaucoma diagnosis in high myopes. This would be very important. The short answer is it is extremely difficult, and there is no very clear ways to identify in a high myope whether he or she has glaucoma or not. Jost Jonas always said that every high myope has glaucoma until proven otherwise. And yes, we take into consideration retinal nerve fiber layer thickness as well, but we need to be aware that there is no normative database of high myopes, and that again, the eye length in itself affects the nerve fiber layer thickness, and you have to be careful relying on RNFL only anyway in glaucoma, but in myopia, you have to be even more careful. I have difficulties in detecting the first signs of glaucoma in patients with high myopia. What do you recommend? What should I pay special attention to? This is a quite similar question, and I can assure you everybody has problems in high myopia. It's not only you, it's everyone who has problems. And what do we need to pay special attention to? Well, obviously, the biggest thing that you have to pay attention to in high myopes is definitely the progression of visual fields. If you have visual field defects that are glaucomatous and you see them progressing, there is a need to intervene. And this is maybe true for all glaucomas, but it is particularly true for high myopic glaucomas. If you see visual field declines that are significant over time, pay specific attention, and if possible, see the patients more often. Have very frequent investigations to get very clear trend analysis over time. For AI-assisted ophthalmic tools, has it gone through variation in different ethnicity? I talked about this already. We have different ethnicities, but we do not have all ethnicities, and we are lacking African data. Does polygenetic risk score add value in your current AI models? Yes, it would add value, and we are working on these polygenetic risk scores, but it is difficult to do this type of work because not every patient does have genetic profiling, and again, it's a lot of work, and you need a lot of data doing this. We are doing this in international consortia. There is also a big effort by the group in Moorfields Eye Hospital that are looking into this. In your opinion, how soon would the model become commercially available? I hope that the model will not become commercially available, but freely available. And I would say a realistic time frame is maybe 3 years. Difference in visual defect between glaucoma patients and high myopia patients. Well, this is an important thing. We know that high myopia can mimic visual field defects in glaucoma. Most likely the reason is because when the eye is elongating during the development of high myopia, there can be mechanical cracks in the retinal nerve fiber, and this can lead to retinal nerve fiber layer defects that produce glaucoma-like defects. Now, one of the differences is that glaucomatous visual field defects are more likely to progress, although the work of Kyoko Onomatsui also indicates that myopic visual field defects can progress. One additional hint is to look at the structure function, as I've shown you with the Gabway heath maps or any other tool for looking into this. But it is complicated, and in many cases, it is very, very difficult to get a clear diagnosis whether this visual field defect is solely myopia related, is solely glaucomatous, or is a combination of both. What's the best diagnostic tool for glaucoma and alternative measurement? Well, as I said, I mean, the best diagnostic tool for glaucoma is a combination. Usually, glaucoma diagnosis based on one single instrument does not work because none of the instruments has the required sensitivity and specificity. And as for any type of intervention, the key element is the clinical diagnosis by the ophthalmologists, and you can use the diagnostic tools to support this diagnosis, but not to replace this diagnosis. Please, at what point must you start glaucoma management? Is it when there is structure damage on OCT or when there is a functional damage on the visual field defect? This is again something that cannot easily be answered because it depends on a lot of different risk factors. What I can say once you have a clear diagnosis of glaucoma, it is required to start treatment, and this is also supported by the evidence of the large-scale trials. In pre-perimetric glaucomas or in glaucoma suspects, it depends to a large degree on the number of risk factors, but also on the level of intraocular pressure. You know, if you have, it is of course, let's say you have a patient with ocular hypertension, and you have no structural or functional signs of glaucoma, but an intraocular pressure of 23, I think there is not necessarily a need to start treatment. If the same patient has an intraocular pressure of 40, then you should consider to start treating, because with 40 IOP, there is a very high likelihood that the patient will develop glaucoma or glaucomatous damage in the next couple of months. What are the standards for screening glaucoma in community? Who will be screened glaucoma in a community? This is also a very important question because you know that in diabetic retinopathy, this is the retinal disease where we do have screening programs. And one of the reasons why we do have screening programs is because we can do targeted screening. Because only those patients who have diabetes can obviously develop diabetic retinopathy. In glaucoma, it is not that simple because basically everyone can develop glaucoma. Nevertheless, it is also clear that the risk of having glaucoma increases with age. So I would say there is maybe a certain age threshold that gives a realistic threshold for screening. Maybe, but this is just a guess. One needs to look into the cost effectiveness, but maybe age of 50 and above might be a good target. In patients with high myopia and posterior staphyloma, visual field is not reliable. How would Prof monitor these eyes, especially they also have optic disc abnormalities, example, inverted U-shape optic disc? How useful is AI in these cases? Well, my honest opinion to these are, with or without AI, these are very, very, very complicated cases because when staphyloma starts to develop, the fate of these patients is usually anyway very bad. And this is a very critical thing. I think what we need to urgently look for is in these highly myopic patients with staphyloma, the key element that we need for the future is a treatment of staphyloma. So I would also say don't overestimate AI. Yeah, AI can do a lot of things, and glaucoma is in principle a good disease to screen with AI because we have treatment available. But also be aware that if we have no treatment available, screening for the disease with AI doesn't make so much sense. Consider, for instance, dementia. We can maybe screen for dementia nowadays, for incident dementia even, but why is it helpful? We do not really have good ways to treat dementia, to retard the development of dementia. Why should we then screen for it? It doesn't make much sense. It is not cost effective. And the same is true here. High myopia, posterior staphyloma, we don't have a good treatment. So AI cannot help really here. Here, research really needs to go towards ways to treat staphyloma. So to maybe something like localized scleral cross-linking. This is something we are also working on in Singapore, but AI cannot help in diseases that cannot be treated. How is the real implementation of the G-RISC in the daily practice now? Do the clinicians submit the fundus photo to the program, or is it already connected to the LCT and machines? How long was to establish the G-RISC? Yeah, what we are currently doing is we are doing this in a test phase. Indeed, the fundus photos are automatically uploaded to the G-RISC. There is no prospective study for G-RISC. All this is done on retrospective data, but we are now also, as part of this, doing a longitudinal prospective study. To what extent do glaucoma accuracy and consistency during visual field testing, such as Humphrey, affect the diagnosis and monitoring of glaucoma pressure by an optometrist? Yeah, I think this is very much dependent on the country. In some countries, their optometrists have almost taken over the entire monitoring of glaucoma progression. In others, this is not the case. And I think more or less it is the same like in ophthalmologists. You need a reliable number of tests in order to be sure. So I have told you that you need 7 or 8 visual fields to really get a reliable visual field progression analysis. And this is true in both an ophthalmology and an optometry setting. When to start glaucoma treatment as a general ophthalmologist, or should we always refer to glaucoma specialist? No, definitely not. There is no reason in early glaucomas. Very often, when glaucoma is diagnosed and you have a clear diagnosis of glaucoma, you are sure it is glaucoma, you initiate treatment. It is not a very late stage case, and then you continue to observe the patient, and there is no progression over time. The patient is happy with the IOP lowering, and let's say you start medical treatment. There is definitely no reason to refer to glaucoma specialist. The glaucoma specialist is of utmost importance in those cases that are very advanced, complicated, or those that show progression despite treatment. AI will replace the doctors in the future. How long will it be happen according to your opinion? Now, I don't think that this is a topic that is often discussed. I think that it will not replace doctors at all, but it will change what doctors are doing. And I generally don't think that AI is such a revolution. There was always innovation, and I'm not 20 years anymore, as you see from my video, and I still remember very well the times when OCT was introduced, and it changed what ophthalmologists were doing, because suddenly you could see three-dimensional representations of the retina and the optic nerve head, and this was a revolution in terms of what we could diagnose. And AI is another tool that improves it, and as such, hopefully, and this is really my hope, it will be the same number of doctors, but they can do more useful things. Diagnosis will be faster, and as such, doctors will have more time to really look into the very relevant things. And one of the very relevant things is to take care of these glaucoma patients that have a high risk of getting blind. At the end of the day, I think what is the hope with AI? The same number of doctors, the same investment into the healthcare system, but less people who are getting blind because of better diagnostic and prognostic accuracy. How long does it take to check for glaucoma to see its progression? And what is the essential test for evaluating or monitoring the progression of glaucoma? Yeah, this is again a question. In the early stages of the disease, I feel that OCT is extremely useful, particularly if the visual field defects are still very subtle. In the late stage of the disease, definitely the visual field is the most important test to see whether the patient shows progression or not, together with the intraocular pressure that anyway needs to be monitored at each visit. Thank you for insightful talk. Just wondering if your team has other predictive studies with the use in AI in determining the effect of systemic risk factors on glaucoma progression. Yes, we started to do this, but one of the problems is that usually, even if it depends very much on the hospital how well these systemic diseases are evaluated. I think this is a very important point. I think this is also something in the future where AI could play a major role. You know that many patients who have glaucoma do have systemic disease, particular cardiovascular disease. Many of these patients show systemic hypertension. And I think it is of utmost importance, and here AI can also help, that when a patient is diagnosed with glaucoma, that we at the same time look into systemic disease and ensure that this systemic disease is treated sufficiently. Do you believe that AI technology in devices like AirDoc could become the new standard of retinal screening, or should it still be combined with manual analysis by Optom? I'm definitely, I'm definitely convinced that the second is the case, and I can tell you the reason why. Uh, Usually AI, as I've told you, the reasons why works very well in diseases that are common, but it works less well in diseases that are very rare. Let's say, for instance, Stargardt. Yeah, Stargardt is rare, and it can look a little bit like age-related macular degeneration, particularly in later stages, but it is a different disease. And we have to be very, very careful that these rare diseases, and you know that Stargardt is a potentially blinding disease, are not overseen. And that's the reason why I think that, at least for the moment, and at least I would say for the next 10 years, I foresee that AI can be used to basically do a basic analysis, but then it is still required that that an optometrist or an ophthalmologist or whoever, but somebody who has training, looks over these data and see what the AI is doing is correct. And this is particularly important when we think about large language models, because large language models are non-supervised. And this means if they are wrong, this wrong information is by the definition always augmented. So you do have an augmentation of wrong results. Do you believe that AI technology how about OSAS and glaucoma? Yeah, exactly. The question is always, when it comes to these more critical questions. I mean, glaucoma versus non-glaucoma is always relatively easy, but it is always difficult in these cases that are more rare. Okay, I think this is all the questions. We have anyway exceeded the time by more than half an hour. but I told CyberSight that I would be available to answer all questions and I saw that I answered 46 questions. I hope that I answered them to a degree that you are satisfied. If you have any additional questions, you can also contact me by email. And I would like to thank you for your participation. I've seen that we have something like 330 participants, which is quite exciting. And I wish you a good rest of the day wherever you are. Thank you.